Hey, what's up, you guys? I have a very interesting case that I want to share with you, one that I presented several months ago back when I was on the ward service, and it had a lot of really great learning points, so I thought it'd be a very fantastic one to show you guys today. So this was a morning report that I did at UC Davis here a few months ago, and just as a disclaimer, many aspects of the case, including the patient's age, gender, and other specific details, have been modified to protect patient privacy. So I just wanted to go kind of through the day of a call day where we are admitting patients. And so this is kind of what the process is like. So we're in the middle of rounding. We've got our workstation on wheels, which I loved bringing around on rounds. And we've got our team with our med student, our intern, our attending. And all of a sudden we get a page in the middle of rounds. So I give a call back and the screening hospital says, we have a new admit for you for abdominal pain. So they basically say, this is a 45-year-old man coming in with abdominal pain for the last 2 days. His LFTs are elevated and he has hyponatremia with a sodium of 124. He has a leukocytosis of 16, and his imaging showed cholelithiasis but no cholecystitis, and some enlarged lymph nodes concerning for malignancy. So first thing I do just really quickly is take a quick look at the vitals and make sure that everything is stable. And you can see that he's afebrile, his blood pressure is pretty good. He is a little bit tachycardic, 109 to 121. Normal respiratory rate. His O2 sats are slightly low and he's on 2 liters nasal cannula. As the hospitalist mentioned, there is a leukocytosis with a white count of 16.6, so fairly good elevation in the white count. And the chemistry panel, as soon as seeing this, you'll definitely start to perk up as a medicine or internal medicine doctor. So sodium 124, chloride 87, bicarb 16, and LFTs elevated as below. And in terms of the imaging, like they said, there was cholelithiasis without evidence of cholecystitis. There's some hepatomegaly and non-specific elevated hepatic artery velocity, which may be seen in inflammatory states. And then there was also a CT abdomen and pelvis, which showed mild lymphadenopathy and splenomegaly. Differential includes infectious or inflammatory states, as well as lymphoproliferative disease, and then some possible bowel wall thickening. So at this point in the morning report, I kind of wanted the interns to interpret this comprehensive metabolic panel for us. And so I brought it over here and was like, can one of you interpret it? And obviously some of the things that they mentioned were the low sodium, and then the acidemia with a bicarb of 16, and then the elevated LFTs, specifically with a predominant elevation in the alk-phos. And so the first thing that is definitely notable is the high anion gap metabolic acidosis. So at this point, I had the medical students kind of tell us, how do you calculate an anion gap and what is an elevated anion gap? So of course, an elevated anion gap is generally, typically defined as an anion gap greater than 12. But the way you calculate it is going to be the sodium minus the sum of the chloride plus the bicarb. So in this case, we get 124 minus 87 plus 16, which if you do the calculation is going to equate to an anion gap of 21. So that's why we're calling this a high anion gap metabolic acidosis. The next question I ask medical students is, how do you calculate appropriate respiratory compensation for a metabolic acidosis? And the answer to that is going to be Winter's formula. And if you remember the formula for that, that is going to be 1.5 times your bicarb plus 8 plus or minus 2. So in this case, this patient has 1.5 times 16 plus 8 plus or minus 2, which equals 24 plus 8 plus or minus 2. So he really should have 32 plus or minus 2 PCO2 in order to compensate for this metabolic acidosis. So I brought up his VBG here, and you can see that he actually has an elevated pH of 7.46, and his PCO2 is 27, which is lower than expected compared to the Winter's formula. So he has both a metabolic acidosis as well as a respiratory alkalosis because he's over-breathing and breathing off more CO2 than he should. Of note, his primary acid-base disorder is probably actually more of a respiratory alkalosis because he has an elevated pH. But basically, this is the process of how you would go through calculating an anion gap and then also calculating compensation for an anion gap. Now, the next thing I asked was how to calculate delta-delta. And I know a lot of people are going to kind of groan when they hear about delta-delta, but it's actually not that complicated to calculate. The first question is, why do we calculate or why do we care about a delta-delta? The reason we calculate a delta-delta is to figure out if this is a pure anion gap metabolic acidosis, or if there is an additional component of a non-anion gap metabolic acidosis or metabolic alkalosis on top of that as well. So like I said, it's not complicated to calculate at all. I just think a lot of times it's not really explained that well. So the way you calculate it is the change in the anion gap over the change in the bicarb. And that's why it's called the delta-delta. And so what you do is you take the patient's anion gap and then you subtract it from what a normal anion gap is going to be. So in this case, what is a normal anion gap? And the answer to that is going to be 12. And then in terms of the change in bicarb, what is a normal bicarb value? So normal bicarb we consider is 24. So after that, you just plug in what the patient's anion gap is here and the patient's bicarb here. And so if the patient we have here, their anion gap is 21, and then his bicarb is 16, then we get a delta-delta of 9/8. And the way that you interpret it is actually fairly simple. So if the ratio that you have is less than 0.8, then you have a non-anion gap metabolic acidosis plus a high anion gap metabolic acidosis. If it's 0.8 to 2, then it is a pure high anion gap metabolic acidosis. And if it is greater than 2, then you have a high anion gap metabolic acidosis plus a metabolic alkalosis. So again, anything less than 0.8 of a ratio is going to have high anion gap metabolic and non-anion gap metabolic acidosis. 0.8 to 2 is going to be a pure high anion gap metabolic acidosis, and greater than 2 is going to have a metabolic alkalosis. So this patient, as you can see here, his ratio is 9/8, which puts him in this ratio here. So he has a pure anion gap metabolic acidosis. Finally, I wanted the medical students and interns to differentiate what kind of liver injury he has. So he has elevated LFTs, and most importantly, the pattern of injury he has is a cholestatic pattern of liver injury. So what are the two types of liver injury that you may find? The first kind is going to be a hepatocellular, and the other type is going to be a cholestatic pattern. So what you're going to see in a hepatocellular is that the AST and ALT are going to be very, very much elevated, whereas the alk-phos and bili are going to be slightly elevated. Whereas for a cholestatic pattern, we're going to see a more mild elevation in the AST and ALT, and an alk-phos and T-bili that are more increased. And the reason this is so important is because it helps us, form different differentials, whether this is a pure hepatocellular pattern of liver injury versus a cholestatic pattern of liver injury. And in this case, you can see the patient has very high alk-phos, elevated bilirubin, and more mild elevations in the AST, ALT. So this is why he has more of a cholestatic pattern. All right, so this is again going back to all of the labs and the information that we have right now. And overall, the impression is, he's definitely got some real medical issues going on, and it's going to be very interesting to delve into this later. But as of right now, he's fairly stable. So, we're still rounding. I basically tell my attending, hey, Dr. Mola, this patient seems stable. Let's finish rounds, and then we'll see him afterwards. And so after that, we continue rounding on our patients, doing bedside rounds, which I've been really enjoying lately, as you've probably know from watching my other videos. And we go back to the workroom where we start to review a little bit more of his information. And one of the first things we pull up is his chest x-ray. And so at this point, I wanted the interns and medical students to interpret this chest x-ray. Are there any abnormal findings that make this seem very concerning? And mainly the thing that people notice is right here, this kind of looks a little bit full. And I'm actually curious to hear what Nick, one of my friends, has to say about this chest x-ray. But I'm not sure if that's an enlarged pulmonary artery or what's causing this kind of finding right here. But otherwise, we kind of discussed, this isn't like a super impressive, crazy radiograph until you actually read the radiologist's impression. And in terms of their impression, they said this is a bilateral widespread miliary pattern with differentials including disseminated infection such as coccidiomycosis, TB, other infections, or non-infectious granulomatous disease. So obviously seeing this, a lot of alarm bells are starting to ring. And one of the things that I had a question of is, does this seem like if this was a chest x-ray that you saw when you were admitting this patient, would you have immediately thought, this was such a concerning finding? Like, from your own read, would you have really thought of a miliary pattern? Because typically, when I think of a miliary pattern, I think of x-rays like this. Like this is what's going to show up on your board exams. Like look at just this diffuse disease miliary pattern all throughout, opacities all throughout the lungs, like very obvious. Whereas here on the bottom left, we have a normal chest x-ray. And on the bottom right, we have our patient's chest x-ray. And so I think this really shows the benefit of having radiologists read these because, looking at this chest x-ray, it's not super obvious to me that there's a miliary pattern of radiographic findings here. And so definitely curious to hear your thoughts about that. If you had seen this chest x-ray, would you have found that miliary pattern or what would have clued you into that? Now moving on to his CT chest. Now I just got one slice here, but you can definitely see some of those findings again. So we've got definitely some ground glass opacities, some nodules, and a lot of these findings all throughout here, as well as some hilar and mediastinal lymphadenopathy. So he's definitely got quite a bit of findings all throughout here. Again, from the radiologist's official read, there were widespread miliary micronodules throughout the lungs, in addition to perilymphatic nodules, scattered ground glass nodules, a few patchy consolidations, and a cavitary nodule in the left lower lobe. There are also focal ground glass opacities in the bilateral apices with reverse halo sign. And if you remember anything from your radiology course, you may remember that the reverse halo sign is a sign of what? Typically, that's going to be a buzzword for aspergillosis. So again, extensive axillary mediastinal and hilar lymphadenopathy and dilation of the main pulmonary artery, which may be suggestive of pulmonary hypertension. Again, these imaging findings were concerning for disseminated infections such as cocci, tuberculosis, fungal infections, and metastases. So at this point, we've done some of the basic review of the patient's labs and their imaging, and so now it's time to go see the patient. And when you go down to the bedside and talk to the patient, he says his chief complaint is not abdominal pain, rather it's hiccups for the last 2 days. Now at this point, I had the group stop and think about what specific questions they would want to ask this patient. And there were 2 specific questions that I was hoping people would answer. And the audience, when I was presenting this morning report, actually did get both questions correct. And this is totally based off of not his chief complaint, but everything we know about the patient so far. And so the 2 questions that I was hoping the audience would ask is, has he been having any fevers, night sweats, or weight loss? And then, has he had any travel or any risk factors, such as being homeless, incarcerated, or any IV drug use? So why are we asking about this? Because first of all, he's got miliary pattern on his imaging, and he has all these concerning findings. One of the things that's going to really clue us into a history of TB is going to be fevers, night sweats, and weight loss. And then finally, these are risk factors for TB right here. So any recent travel to endemic areas, homelessness, incarceration, IV drug use, again, are all going to be risk factors for tuberculosis. So let's move on to the H&P, which I was able to collect from the patient, along with my really great intern that week. But his chief complaint was intractable hiccups for 2 days, no significant past medical history. He states that he was in his usual state of health until a month ago when he began to experience weight loss and night sweats. It's unclear how many pounds he lost, but he states his pants fit looser than before. His night sweats are drenching and soak through his bed sheets. 2 weeks ago, he went to an outside hospital due to headache, which resolved with treatment. He was sent home, but he continued to have symptoms of fatigue, nausea, and vomiting. And 2 days ago, he developed intractable hiccups that has prevented him from being able to sleep, so his girlfriend told him to come to the ED. Here's just a quick summary of some of his findings in the ED. And then in terms of his risk factors, he denies any recent travel, any history of homelessness or incarceration. He denies a history of IV drug use and denies history of blood transfusions. He denies any new sexual contacts and is monogamous with his girlfriend, but he states that we haven't had sex in a long time. There's nothing really in his past medical history. Past surgical history, he's just had this groin abscess drained in the past. No known drug allergies, no current medications, no family history. In terms of residence, he lives in Sacramento by himself in a house. He's not currently working. He used to smoke 1 pack per day for 20 to 30 years, but he says he quit 1 month ago. No alcohol use, denies drug use, and he's independent in his ADLs, and his hobbies include going to the casino. Moving on to his physical exam, we're going to review his vitals one more time. So he's afebrile, blood pressure again was normal, mildly tachycardic, normal respiratory rate, and slightly low O2 sat. He's on 2 liters of oxygen. On physical exam, he is a pleasant middle-aged man. He is hiccuping repeatedly during the exam, but is otherwise in no acute distress. And this was really great by my intern because my intern asked him to open his mouth. And when he opened his mouth, there was actually some slight signs of thrush within his mouth. And then he had bilateral cervical lymphadenopathy, about 1 centimeter lymph nodes in the supraclavicular regions, and some smaller lymph nodes on the right side. His heart sounds a little tachycardic, but otherwise no murmurs. And his lungs were notable for crackles diffusely in the bilateral lung fields. His abdomen was soft, non-tender, and non-distended, but he did have multiple bilateral inguinal lymph nodes that were palpable. For his extremities, there was no edema anywhere, but we did find that he had epitrochlear lymphadenopathy. He had no midline back tenderness, and he was alert and oriented times 3. So just talking briefly about epitrochlear lymphadenopathy. Epitrochlear lymphadenopathy is really where you're going to be feeling around this medial epicondyle near the elbow. And if you ever feel lymph nodes in this region, that is 100% abnormal. Nobody should have palpable epitrochlear nodes. And some of the main differentials that you should think about when you feel epitrochlear lymph nodes are things like HIV, syphilis, lymphoma, and things like that, and skin malignancies and infections, as you see here. Here's just a picture of epitrochlear lymphadenopathy. Our patient's lymph nodes were not this pronounced, where you could just see them visibly, but this just gives you an idea of the distribution of where you should be feeling on the patient's elbow in order to feel these lymph nodes. All right, so going back to the patient, one of the things we like to do in internal medicine is what's called a problem representation. And this is something that we kind of try to distill all the salient features of the patient's history and their symptoms in order to create an illness script, which is basically something that is used to trigger a pattern, like a pattern recognition, so you can try and identify what to work up in this patient and what you think the most likely diagnosis is. Because there's a ton of information here. We got to distill it down to like a 1-sentence summary of what's going on with this patient. So the quick and easy way to form a problem representation is to first think about the demographic of the patient, pertinent medical history, the time course, is this acute, subacute, or chronic, and then also what pertinent symptoms they're having. So for the demographic of the patient, you want to list if this is a young patient, middle-aged patient, or elderly patient. And so in this case, he's in his 40s, so he's going to be a middle-aged man. And pertinent history, he doesn't really have any. He's otherwise been healthy, so previously healthy. And he's been having these symptoms for about 2 weeks or so, since that's when the onset of like the headache happened and all this like kind of vague constitutional symptoms. So I would call this subacute. If you're thinking usually acute, it's usually less than 2 weeks. Subacute is more of like the 2 to 4 weeks mark, and then greater than 4 weeks or greater than a month, you're more starting to think about chronic conditions. And then finally, what would you say his pertinent symptoms are? Well, really, for this particular illness script that I'm thinking of, it's going to be his weight loss, his night sweats, and his lymphadenopathy. And so when you put all of that together, you get something like this. You get a previously healthy middle-aged man presenting with subacute weight loss, night sweats, and lymphadenopathy. And immediately, just this sentence by itself should trigger some potential diagnoses in your differential. So there were 2 main ones that I think this would trigger. The first one is going to be lymphoma. You're going to have constitutional B symptoms, you're going to have lymphadenopathy, and you're going to have weight loss, all symptoms of a malignancy such as lymphoma. And the other one that you could have is HIV. HIV can again present with a lot of these findings, in addition to that thrush that we saw in the patient. And some additional differentials that I thought about for him, obviously TB with miliary findings on imaging, and if he has lymphoma or HIV, he's certainly more prone to having TB at this point. A disseminated fungal infection, for example, cocci, which was noted by the radiologist, or some kind of other metastatic process going on, or cancer. So after talking to the patient, we go back to the workroom, and at this point, our pager just starts going off like crazy, and we just keep getting admission after admission. And it's basically, you get a new admit, you get a new admit, everybody gets a new admit. And so obviously we are, trying to deal with all these new admits that are coming in. And when we finally get back to the workroom again to take a look at some of the labs that have come in, we finally get this result, and that is HIV positive. So now the question is, what would you do, and how would this change your differential for this patient? And what orders would you place? So while you're thinking about that, I thought it'd be a great time to do a problem list for the patient, because this is something that we do a ton in internal medicine, and knowing how to generate a problem list is one of the major things that you have to do in residency, especially as a medical student and an intern. And so I brought up all of these labs again for you, and I asked the room to basically help problem list this patient. And really, you want to identify what are like the top problems for this patient at this point. And what we kind of decided on was number 1 problem for him is going to be HIV/AIDS, because this is probably something that may be contributing to all these processes that might be going on at this time. Problem number 2 is going to be his bilateral lung infiltrates, concerning for PJP versus community-acquired pneumonia versus tuberculosis. He's clearly septic with tachycardia and leukocytosis, and he's got this headache and intractable hiccups, which I kind of grouped into one problem. He's got this cholestatic liver injury, and he's got a hypotonic hyponatremia. And so this is my basic problem list that I generated for this patient. So going through them one by one, let's talk about how we're going to manage and approach these. So for HIV/AIDS, the first thing I wanted to talk about really quickly is, when do you consider it AIDS? And typically, you're going to think about a CD4 count less than 200, or an AIDS-defining illness, which is usually going to be an opportunistic infection. For example, if somebody had PJP, that would be considered an opportunistic infection, and then you'd be able to call somebody having AIDS. So when talking about HIV/AIDS, I actually have this nice dot phrase that I like to use, and you can find it in my dot phrases, assessment and plan HIV. And so it really helps prompt you to tell when the last labs were drawn, what their CD4 count is, their viral load, and then kind of what medications they're on. And so one of the labs that we want to check is going to be the CD4 count, the HIV viral load, HIV genotype, and then often we want to check the EBV and CMV status as well. And then once results are back, we'll do an ID consult to initiate antiretroviral therapy. We may need to do all of these outpatient things to help get them set up with HIV clinic, infectious disease, social work, things like that. And a couple things here that I have in the dot phrase just to remind us of some symptomatic treatments. So if somebody has thrush, then you can consider nystatin swish and swallow, or clotrimazole troche, or fluconazole. And then if they're having diarrhea, you check C. diff toxin, GI biofire panel, stool, ONP, cryptosporidium, things like that. And then you do not want to initiate antiretroviral therapy in tuberculosis or cryptococcal meningitis due to the risk of iris. And the reason I left this part blank right here is because I wanted to go over some of the opportunistic infections that can present at different CD4 counts. So what specific infections may you be thinking about in patients with a CD4 count of 200 to 500? And that's really going to be, if they're greater than 500, they have an increased risk of any community-acquired organisms, for example, just any run-of-the-mill bacterial pneumonia. But also from a CD4 count of 200 to 500, you're going to have that increased risk for tuberculosis. CD4 count less than 200, what are some of the opportunistic infections that you're thinking at that point? The big one is going to be Pneumocystis jirovecii, or PJP. But you're also going to see cryptosporidium, which causes profuse watery diarrhea, Candida and thrush, and fungal pneumonias. Less than 100, what are you starting to think about then? That's really the big one on the boards is going to be toxoplasmosis. And then less than 50, what kind of infections at that point? So you may see CMV, Cryptococcus, MAC, which is going to be kind of a big one, and primary CNS lymphoma. So for these, I have this part of the dot phrase as well. So you want to start Bactrim for PJP prophylaxis until CD4 count is greater than 200 for more than 3 months. And you want to consider azithromycin for MAC prophylaxis until CD4 is greater than 40 if there is a delay in initiating antiretroviral therapy. So typically, we actually don't do MAC prophylaxis anymore unless there's some reason that you're not going to be able to give them antiretroviral therapy. Otherwise, we don't usually do MAC prophylaxis anymore per the most recent guidelines. So at this point, I'm curious what you guys think this patient's CD4 count is going to be. So wager your guess right now what you think his CD4 count is. And then I'm going to pull up his counts right here. And the way to interpret this in our EMR is you want to look at this CD3 plus CD4 absolute count, and you'll see that his CD4 count is 53. So how close was your guess to what this patient's CD4 count was? All right, problem number 2 is going to be his bilateral lung infiltrates concerning for PJP versus community-acquired pneumonia versus tuberculosis. So here's my assessment and plan for him. So he had admission imaging notable for a miliary pattern, numerous lung nodules, and diffuse lymphadenopathy. In the setting of immunocompromised patient with weight loss and night sweats, we will begin TB rule out despite lack of other risk factors. His differential includes TB, atypical pneumonia, and PJP, so we'll also treat empirically for CAP and send sputum for PJP. Notably, the patient was without respiratory complaints and is satting well on room air. In terms of our plan, we're going to consult ID. We're going to rule out TB with the MTB PCR and AFB smears. We're going to ask ID basically if we should treat for PJP empirically or try and just wait for the sputum sample. And then we'll start treatment for community-acquired pneumonia. And a question I'd like to pose to you guys is, what antibiotics would you have chosen in this situation? Would you have just gone with typical community-acquired pneumonia coverage, such as ceftriaxone and azithromycin? Or would you have done something more broad? In this case, I was a little bit concerned about this patient. I'll bring this up a little bit later because I initially started with ceftriaxone and azithromycin, and I eventually broadened him to more broad-spectrum antibiotics such as cefepime and vancomycin. So I'm curious to hear what your guys' thoughts on the antibiotic choices for this patient. We're going to get some of these things: gram stain, Legionella, strep pneumo, fungal culture, and we're also going to get cocci serologies. I also wanted to go do a brief review of community-acquired pneumonia, and this is another dot phrase that I have. It's the assessment and plan for pneumonia. So one quick thing is that, how do you determine if a patient needs to be admitted or not for pneumonia? Some of the quick scores that you'll see used a lot in the ED are going to be the CURB 65, and then the pneumonia severity index, or the PSI score, is what internists will use a lot to determine if this patient needs to go to the wards or if they need to go to the ICU. And the main thing I want you to learn is the 2019 IDSA guidelines. They basically said that blood cultures, sputum culture and gram stain, Legionella, and strep pneumo should only be obtained if there is severe community-acquired pneumonia or suspected MRSA and Pseudomonas. In terms of procalcitonin, this is something that we can use to check for signs of a bacterial inflammation. And really, we can use it to consider discontinuing antibiotics if there's a greater than 80% decrease from the peak, or the absolute value is less than 25 to 50. And this is based off the PRO-RADA trial. So we really shouldn't be using procalcitonin to guide us when to start antibiotics, but it can be useful to help us guide when we can stop or safely discontinue antibiotics. If influenza positive or Tamiflu is indicated regardless of duration of illness, and anaerobic coverage is not recommended for aspiration pneumonia unless abscess or empyema is suspected. So again, this is a huge point because this comes up all the time. People say aspiration pneumonia, there's an anaerobic organism involved, we should give metronidazole. But in this case, based on the 2019 IDSA guidelines, you should not give anaerobic coverage for an aspiration pneumonia. So again, going back to the severe community-acquired pneumonia, how do we define this? Like, did this patient actually meet criteria for severe community-acquired pneumonia? So really, that's going to be some of these criteria here. So septic shock, respiratory failure requiring mechanical ventilation, those are kind of obvious. Or at least 3 of a respiratory rate greater than 30, a P to F ratio less than 250, multi-lobar infiltrates, which our patient did have, and then all of these different things as well, which he did not have. So actually, he did not quite meet criteria for severe community-acquired pneumonia. And so that's specifically why I'm curious what antibiotics you would have chosen for this patient. In terms of his sepsis, he was tachycardic to the hundreds on admission. His leukocytosis was 16 and went up to 18. He was afebrile and his blood pressure was stable, and this is possibly from his pneumonia versus HIV infection. He did get 2.5 liters of normal saline in the ED. His lactic acid was elevated from 3.7 down to 2.8, and suspect likely type B lactic acidosis, given no signs of hypoperfusion. So what is the difference between a type A and a type B lactic acidosis? So type A lactic acidosis is going to be the one where it's true tissue hypoperfusion. For example, somebody's in septic shock and their blood pressure is so low that they're not actually perfusing their tissues and they're starting to undergo anaerobic metabolism. And then that's when you're going to generate that lactic acidosis. But a lot of times you're actually going to see a type B lactic acidosis as well. And these are causes that are not due to hypoperfusion. And it can be from a lot of things. Typically, we'll see it a lot in patients with liver dysfunction because they're not able to clear lactic acid, which the liver is involved in doing. You also see it in malignancies, especially hematologic malignancies. HIV, different infections can cause it, and then different drugs can cause it, especially like metformin is a classic one that we associate with a possible type B lactic acidosis, even though the evidence for that is not super strong. But yeah, this is basically what we're talking about when we're talking about type B lactic acidosis. The next problem is his headache and intractable hiccups. So he had a new onset headache 2 weeks prior in the setting of newly diagnosed HIV, and also with intractable hiccups concerning for his central mechanism. We'll obtain imaging to rule out progressive multifocal leukoencephalopathy, but I did write low suspicion, a brain abscess, which he could be at risk for with HIV, or brain mass or lesion. So I actually ordered an MRI brain. I ordered baclofen for the hiccups because baclofen could potentially act centrally to kind of reduce the hiccups. And if worsening headaches or signs of meningeal irritation, we'll need a lumbar puncture. So I have a really quick question for you guys. Is there anything else that you would have ordered in terms of workup or in terms of treatment that you would have just sent off at this point for this potential problem? He's got this headache, he's got HIV. Is there something else we should have done? And should we have gotten that LP right away? Curious to hear what you guys think about this. Of note, by the time he came to us, he was not complaining of a headache, but he was complaining of the hiccups. And the headache, it happened 2 weeks ago. He said is basically resolved. So in this situation, would you have gotten that LP, another blood test for something? And put it down in the comments down below if you had another idea for what you would have ordered at this stage. Next, he's got a cholestatic liver injury. And here, we're basically going to trend his LFTs and follow up hepatitis serologies. I also did get a GGT, which was elevated. So it suggests it truly was coming from the bile, the biliary tree. And this is actually a learning point that I had from this case. But HIV plus cholestatic liver injury should trigger a specific illness script for you as well. And I did not know this until our ID colleagues commented on it. So again, let me know in the comments down below if you were able to guess what HIV plus cholestatic liver injury may be associated with, and then I'll reveal it to you a little bit later in this presentation. And finally, his hypotonic hyponatremia, his sodium was 124. We looked at his volume status. He looks possibly hypovolemic or euvolemic, and his urine studies were consistent with GI losses and or SIADH. If you want a quick review of hyponatremia, you can take a look at my hyponatremia guide in my residency guides playlist. All right, and that's pretty much it for his problem list. And at this point, I just want to kind of take a step back and look through the process of putting in orders for a patient, and just to kind of show and demonstrate that thinking about patients and then putting in orders for them is a continuous process. So like throughout the day, you were continually thinking about the patient, trying to rearrange the different puzzle pieces together to figure out what's going on with this patient, and then figure out what the best treatment plan is. And so that's actually normal to be really constantly reevaluating your plan. So for me, here's a bunch of the orders that I put in. And this is, first when I got back to the workroom and found that he was HIV positive, around 12 o'clock. So I immediately put in that immunodeficiency panel that we talked about to check his CD4 count, his viral load, PJP, and I tried to look for some risk factors, urine drugs of abuse screen. And because of his pneumonia or possible pneumonia, I threw on some of these infectious workups, the tuberculosis rule out, and also an ID consult. Now, moving on here, you can really see where I struggled figuring out what antibiotics to start him on. Initially at 12 o'clock, I didn't even start him on antibiotics because he was breathing fine on room air and he didn't even have any respiratory complaints. So I didn't even start him on antibiotics right away. And then around 2:47, I was like, maybe I should, empirically cover for community-acquired pneumonia just in case there is some, bacterial pneumonia on top of all of this. I did put in the MRI brain at this time for the persistent hiccups, and you can tell I was thinking about it earlier. At noon I put in the baclofen, but then later I decided, okay, I should probably be a little bit more concerned about a central process for him because of his HIV and how uncontrolled it is. And I threw on some other things like syphilis, cocci serologies, sputum induction. Then around 3:47, you can see I was obviously like recalibrating and getting a little bit more worried about the patient. I was just getting closer to sign out. So I ended up changing him to cefepime and vancomycin to cover him a little bit more broadly. And so, like I said, you're continually reevaluating the patient. And sometimes you just start to get more worried and you start changing things a little bit. So this is like kind of a normal process of what it looks like putting in orders for a patient. Here, I just said I had that poor nurse in South 1 Annex running in circles that day. South 1 Annex in our hospital is this kind of overflow area where it's just kind of curtains between everything, and it's kind of just supposed to be like a waiting area, but basically this person had like this crazy workup that we had to do, tons of blood tests, tons of imaging and things, and new antibiotics and everything. So definitely had that nurse running around in circles that day. So hospital day 1, the patient said he slept really poorly. He said he continued having a ton of hiccups. So we ended up switching his baclofen to gabapentin and a PPI, which are also potential treatments for hiccups. And we're hoping that would work a little bit better. And then he reported some chest pain with swallowing. So at this point, with the thrush and then this chest pain with swallowing, kind of concerning for esophageal candidiasis. So we actually started fluconazole at this point instead of just the nystatin or clotrimazole troches. He did get his MRI brain, and there was no hemorrhage, focal mass, or evidence of new infection. But there are some few foci of increased signal in the white matter of both cerebral hemispheres, but relatively nonspecific and really not too revealing. There was a small pituitary gland with a partially empty sella, but again, nothing too specific on this MRI brain. And then next, we got our recommendations from the infectious disease team, and these were some great recommendations for us, obviously. So newly diagnosed HIV, and then ALK-Phos out of proportion to AST and ALT which raised concern for possible MAC. So this was what I was alluding to earlier when I was talking to you about that association between HIV and cholestatic pattern of liver injury. This should immediately trigger a differential that should immediately include MAC. This is actually an association that I did not know about until after this patient. The other differential that people brought up was AIDS cholangiopathy, which is when you get elevated liver enzymes because you get strictures from infections that cause strictures of the biliary tract. In terms of the recommendations, they had a whole host of tests they wanted us to send. The Hep B surface antibody, gonorrhea, chlamydia, G6PD, HLA-B57. This is all for them figuring out which antiretroviral to start him on. They also wanted to send a toxo antibody and crypto antigen, quantiferon. They wanted to hold Bactrim for now, so no empiric treatment for PJP. And they actually wanted to obviously stop the vanc, cefepime, and azithro, and instead start him back on community-acquired pneumonia treatment, so ceftriaxone and doxycycline. I did ask them why they wanted to choose doxy instead of azithromycin, and basically they didn't want to affect any of the results of testing for the PJP. And so by doing doxycycline, they can still cover for community-acquired pneumonia without affecting the results for PJP. Continue fluconazole. Please send 1,3-beta-D-glucan and aspergillus galactomannan. Please send stool AFB for MAC, which is something that I didn't know about. That is, you should definitely check in if you're concerned for MAC because there's a lot of GI symptoms you can get with that. AFB blood cultures, ophthalmology consult, and endocrinology consult. And then for the TB, they agree with doing the TB rule out. So just looking into some of their recommendations a little bit more and doing some more reading about it. So MAC in HIV patients is frequently associated with anemia, elevated alk-Phos, and LDH. And the treatment is going to be a few different medications. So the first one is a macrolide, so azithromycin or clarithromycin. The next one is going to be ethambutol. And if they're failing treatment, then you would add rifabutin. In terms of treatment duration, it's a minimum of 12 months and a CD4 count of greater than 100 before stopping. And so treatments for PJP, so if they're severe, you use IV Bactrim, which is preferred over IV pentamidine. For mild and moderate, you can do oral Bactrim or oral dapsone or some other alternatives, but generally it's going to be Bactrim. And then one question I had for the morning report audience was when to add steroids. And there's specific criteria for adding steroids for the treatment of PJP. And that's if their PaO2 on an ABG is less than 70, they have an AA gradient of greater than 35, or their O2 sat is less than 92%. All right, so going back to hospital day one, as I was leaving for the day, I noticed that his bicarb was continuing to drop. So if you look here at 6 a.m., his bicarb was 16, and then at 3 p.m., it's down to 14. So at this point, he now still has an anion gap of 20, but it's just a little bit concerning when you see the bicarb getting worse, especially after you've started, theoretically, you've started some treatment. But he's got HIV that's severely uncontrolled. Most likely it's a type B lactic acidosis. But I just want to make sure his acid-base status is okay. So I threw on a lactic acid and a VBG. And the other thing I noticed was his white count was getting worse. So he went from 16 to 18, and then he's up to 25.7. So definitely a little bit worried about him as I was leaving for the day. His lactic acid continued to worsen, but the patient was not acidemic. So, on admission, his lactic acid was like 3.7 and went down to 2.7. Now it's going up to 5.1 and then 5.9. Looking at his VBG, though, you can see his pH is still very well compensated. If anything, he's alkalemic. And so, we're not really concerned that he's becoming super acidemic or anything. So now we got a nursing note at 9:30. This is going to the night shift at this point. And patient's lactic acid result came back at 5.9. The MD and charge nurse were made aware. An order was placed for an LR bolus, but MD doesn't want another lactic acid to be drawn as the team believes it's not due to hypoperfusion. So here I wanted to ask you, would you have managed this the same way? And would you have been concerned about the rising lactic acid? I think from my perspective, I do really agree with, overnight, we kind of signed out, he doesn't have any signs of hypoperfusion. We do really think this is a type B lactic acidosis. And so I don't really think the way that the night float handled this was wrong. I think it was entirely reasonable to do this, but I'm curious to hear what you would have done in this similar situation if you had gotten paged about this lactic acid. Unfortunately, it was at this stage that the patient's hospital course started to take a turn for the worse. Hospital day 2, there was a nursing note at 3:15, and basically the patient was getting up to go to the bathroom. He asked for assistance from the nurses, and they took him to the bathroom, and he was noted to be very unstable on his feet. They ended up bringing him back to bed, and he was still having a conversation with the nurses when all of a sudden he became unresponsive and stopped saying anything. They checked for a pulse and couldn't find a pulse, and they began CPR and called the code blue. Here's the ICU note, and patient very quickly, was pronounced just 30 minutes later, pretty much. Time of death 4:04. Basically, they responded to the code blue. They got the same story that he was using the restroom. He was talking with the nurses. All of a sudden, became weak and obtunded, and then didn't have pulses. They did about 40 minutes of CPR. They were unable to get ROSC, and the code was terminated. So yeah, I'm curious to hear what you guys think about this patient's hospital course and what we could have done better in this case. And when I was doing this morning report, I really brought up a lot of different things I was thinking about during this case. Did we make any mistakes in the management of this patient's care? Was it because we de-escalated the antibiotics from vancomycin? I don't really think so. And most of the audience agreed too that it probably was not the de-escalation of antibiotics. Was it because we didn't start PJP coverage? No, again, starting azithromycin for PJP, it's not going to kick in right away. And it really didn't seem like he was having any respiratory issues. So I don't think starting PJP coverage was the problem here. And was it because we stopped trending the lactic acid? Like, would you have continued trending that lactic acid? And if so, what would you do with it? If the next lactic acid came back at 6.5, but the patient was still feeling fine, like, what are you going to do with that worsening lactic acid? And patient's blood pressure is good. He's satting well on room air. His pH is normal. So, is it a mistake to have stopped getting that VBG and lactic acid? I don't really know because, we weren't really doing anything with it anyways. There were a couple of suggestions that some of the attendings made in morning report, and I thought they were actually pretty useful and definitely things to consider. So I'm actually curious to hear if you guys would make the same suggestions on some of the additional workup we could have done earlier on and treatment that we could have potentially done earlier on. But even then, they said, based on how far along he was and how long it takes for some of these treatments to kick in, it probably would not have made a difference in his overall course anyways. So again, let me know what you think in terms of what we may have done better or what mistakes we may have made in terms of this patient's care and how we could have avoided this poor outcome. So final diagnosis, still pending. Well, at this point, it's been several months, and so we actually have some of the answers. And the family did request an autopsy, but I wasn't able to find any of the results of that. However, we did find that his PJP did come back positive. He also did test positive for yeast in his blood cultures, so he was having a fungemia. Obviously, very, very severe illness. And so, if we had started on antifungal treatment right away, would we have potentially prevented this bad outcome, or would the treatment have taken too long in order to kick in? His HIV viral load was basically off the charts, just very, very high viral load, so very uncontrolled. And again, we didn't really have a clear explanation or etiology for how he got it. He really denied most risk factors for this. And then just a few days later, the fungemia did speciate, and he was growing cryptococcus, which actually one of the attendings in the morning report had predicted. He was like, this sounds really like cryptococemia with possible cryptococcal meningitis. Fungal culture grew yeast as well, which is not cryptococcus. So in the end, this HIV patient, really basically newly diagnosed, severely uncontrolled with all of these abnormalities, ended up having severe cryptococcemia, and that is unfortunately what ended up leading to him passing away. So the learning points based on this case, we went over a high anion gap metabolic acidosis, delta, cholestatic versus hepatocellular liver injury, and then how to do a problem representation, how to, break it down into each individual piece and then make one sentence that kind of triggers an illness script for you. We talked about HIV management and prophylaxis, a little bit about TB rule out, treatment of CAP and severe CAP. Again, I'm curious to hear about what antibiotic choices you guys would have decided to do. PJP and MAC management, type A versus type B lactic acidosis. And then finally, I just want to talk briefly about dealing with poor outcomes, and that it was actually a pretty tough week because I had an outpatient who also passed away that week, and I had been managing for several years, and they, were very sick, but they had just messaged me a few days before, and it was pretty sad to see him pass away. And then all of a sudden, this patient that we had for just, 36 hours, otherwise healthy before all this stuff happened, pass away too. Definitely could be a hard week, and you can have some difficult weeks in medicine. But you have to also, I think the way to approach it is, to kind of realize that, some of these bad outcomes are going to happen. And a lot of these patients are very sick. And we really can do the best that we can to try and treat them, to give them the best care possible. And then try and reflect on what we could have done better. In this case, that's specifically what I wanted to do this morning report for. He passed away, and 2 days later I did the morning report because I was actually very curious to hear what input, the other attendings and other residents might have had on this case. And sometimes we're just going to have poor outcomes. And so you definitely had to be mentally prepared for something like that. Anyways, I hope this was an interesting case for you guys. I hope you guys learned something. And I'm also, again, very curious to hear what your thoughts are on the case and what you might have done differently. I hope you guys enjoyed watching this. I'll see you guys in the next one. And thanks again for watching. Peace.